Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with CNS examination, now we have started with cranial nerves. Today we'll be dealing with second cranial nerve, that is optic nerve. So this will be introductory part of optic nerve, what you examine, etc. And in second part of this, we'll be dealing with optic nerve pathway and lesions at different levels. And third will be with pupillary examination. So in today's lecture, we'll be dealing with optic nerve and what are the parts of optic nerve, what are the parts of eyeball, what are the functions, etc. So we'll be dealing with anatomy, function, testing, method of testing, pupillary reflex, optic nerve pathway. Pupillary reflex and optic nerve pathway and lesions will be dealing in next lectures. So human eye, we know that the color is because of the iris. So eyeball consists of retina, and in retina you got optic disc. All those axon fiber converge at optic disc and then continue as optic nerve. There is a crossing at the level of optic chiasma. The nasal fiber crosses. Temporal fiber remains on the same side. Then it becomes optic tract. Then it ends in lateral geniculate body, from there into optic radiation, internal capsule, and then finally it ends into occipital lobe. It is concerned with field of vision. Eyeball, retina, and field of vision will be dealing with that particular portion. So approximately the eyeball weigh about 7.5 gram. The length is 2.4 centimeter. It covers fifth, we almost say 5 by 6 part in an orbital cavity. Anterior chamber is filled with aqueous humor. Posterior chamber contains, we call posterior chamber. Then there is a choroid plexus, ciliary process. There is a draining system, and there is some amount of pressure created in the eyeball because of all these structures we call intraocular pressure. So if you look at these are the different components. This is anterior chamber, this is posterior chamber, vitreous humor. There is a area we call as a fovea, or we call macula, optic disc, optic nerve, choroid plexus, retina, and outermost layer, sclera. Then we have got lens, we have got ciliary muscles, we have got iris, and the central part we call as pupil. The function of the eye, retina is for perception of light. Cornea and lens helps in focusing the light on the retina. Rods are for light and cones are for color vision. Extraocular muscle helps in having a binocular vision, means it helps in the movement of the eyeball so that we get a binocular vision. Monocular vision is by a single eye. Field of vision is the area of vision before eyeball or the person. Optic nerve function is vision, colored vision. These are the two main functions. And it also takes part in pupillary reflex. And function of eye are many. Visual perception is because of refraction of the light rays by lens and cornea onto the retina. There is a convergence of electromagnetic energy of light to a nerve impulse, converted into nerve impulse. And then from retina, that is rods and cones. It is electrical impulses transmitted along the axon fibers of those, along with in optic nerve, optic tract, lateral geniculate body, from there into optic radiation, internal capsule, and finally into occipital lobe, where you perceive the light, vision we call, and perception of visual image takes place when it stimulates the occipital cortex. So this is optic nerve. This will be nasal fiber will be crossing, temporal fiber remains on the same side. Then it goes to the lateral geniculate body, then optic radiation, and to the occipital cortex, or we call visual cortex. So visual field is the area you see before you, that is we call outside world. And retinal field is focused representation of visual field, and it is reversed. It is right and left is interchange and up and down is interchange. That is in the retinal field. Monocular visual field is lateral portion perceived by only one eye. And binocular vision is a common area seen by both eyes. There are good number of different drugs which will have effect on the eyeball, and it will have effect on your field of vision, acuity of vision, colored vision, etc. Say like steroid, chloroquine, digitalis, amiodarone, dihydrophenate sodium, ethambutol, chlorpromazine, etc. These are all the different drugs. They will have some effect on a eyeball, and that will have effect on the vision problem. While examining the second cranial nerve, first we always examine the extraocular movement. We do general inspection of the eyeball, eyelid, conjunctiva, sclera, etc. We look at the both eyeball position. We try to rule out nystagmus. We look for strabismus, eyeball movements. All those are important because they also have some effect on acuity of vision and field of vision. And then we check individual eye for visual acuity and binocular visual acuity, visual field, color vision, fundoscopy. We measure intraocular pressure, and then we look at the pupillary reflexes and pupil size and pupillary reflexes. And initially, before we do all this, we always look at the position of the eyeball, and we look for ocular eye movements, strabismus, nystagmus, etc. And also we look at the cornea, conjunctiva, sclera, eyelids. All those are important because they will have some effect on acuity of vision, field of vision. So while examining optic nerve, pupillary examination, visual acuity, pupillary reflex, colored vision, visual field, fundoscopy. It includes all this we have already mentioned before. So all this is a part of examination of second cranial nerve. This field of vision will be dealing in second part, and pupillary reflex will be dealing in the third part. So first we call as an external examination, in which we look at the lids, we look at the lid position, eyelashes, shape, globe, contacts, etc. We look at all those. So lids, surrounding tissue, conjunctiva, sclera, cornea, iris, because any abnormality in these structures can also have effect on acuity of vision. So you look at the conjunctiva, inferior fornix, superior fornix, cornea, limbus, all those structures. Says for example, if a person has got this central opacity, the acuity of vision is bound to be affected. So you look at that, you look at dislocated lens, subluxated lens, ectopia lentis, all those things you should be looking at. And also anterior chamber depth, you can look at lens clarity, extraocular eye movements, convergence, accommodation, that is also important. because all this factor does have effect on acuity. So inspection is a must, and then we go for acuity, field of vision, reflexes, fundoscopy, or we call ophthalmoscopy. So prior to doing this, structure to be inspected is eyebrow, eyelids, lacrimal apparatus, all those whatever we have mentioned. So you can have a coloboma, which can also have effect. You can see there is a gap in the iris part. Here also there is a gap. This is a keratoconus, which can also have effect on acuity of vision. Scleritis, episcleritis, cataract, all this can have effect on acuity of vision. You can have a rupture in the globe, hyphema, dislocated lens. This is dislocated lens. You can see one border of the lens. So this is a dislocated lens. You can have ectopia lentis also. We are not going to deal with pupillary reflex. Pupillary reflex will be dealing separately. Pupil examination should be also done. We'll be doing absolutely separately. Full lecture will be there. Then you can look for the swinging eye movements. All those will be done again in that pupillary reflex. Position of the eyeball. And then we look at the visual acuity. We go for the near vision and far vision. Near vision is by reading from the books, and there are some charts which are available. And far vision is by Snellen's chart and Ishihara charts. These are the two which you can utilize. So visual acuity is done by Snellen's chart, which you keep it at 6 meter distance or 20 feet distance and measure the acuity. We'll be not going in tremendous detail, but if acuity is normal, we call 6 by 6, it is normal. 6 by 12, 6 by 30, there is a visual error. And if a person has got 6 by 5, that means hyperacute. That is very good. You can use the Jaggers card, or we call reading books, etc. for near vision. Rough method is confrontation method, where you compare your own acuity by perception of light, finger counting, reading, counting bars, etc. of the person. This is very important if any person who has got corneal opacity or lens opacity like cataract, etc. Nowadays this is almost replaced by what we call as a computer assessment. So computer almost give you roughly the visual acuity. So that has replaced visual acuity by confrontation method or by using Snellen's chart. But still, while finding out the glasses, Snellen's chart is absolutely necessary. So person has to cover one eye, and you are keeping a Snellen's chart at a distance of 20 feet, or we call 6 meter, and you ask the person to read the lines, and it should be in a vernacular language which the person knows. So you ask the person to read from the top, and that is how it is being done. And then accordingly you put what is the acuity of vision. So you use that Snellen's chart to identify the acuity of vision. So ideally the person should be able to read the sixth line, 1, 2, 3, 4, 5, and the sixth line. And if he is able to read the seventh line, it is almost 6 by 6. So that is how you go for. So that chart is kept at the distance of 20 feet or 6 meter away, and person is said to have a normal vision if he can see the letters from the distance at 20 feet or 6 meters. Then we call that as 20 by 20 or 6 by 6. That is far vision. So depending upon the size of the letter, person should be able to read those particular letter at that distance. So then we call that as a 6 by 6. So the each line letter, first letter is 60, second is 36, third line is 24, then 18, 12, 9 and 6. You can see these are 4, 5, 6 and 7th line. So if he is able to read this line, it is called 6 by 6. If he can read only this letter, we'll say that it is 6 by 60. So depending upon what he is able to read accordingly. And if he can read this 8th line, his acuity is much more sharper. We call 6 by 5. So we mentioned 20 by 200, 20 by 100 like that. And when it comes to 20 by 20, we call that is equivalent to 6 by 6. This is. And when it is more, we call 20 by 10 or we call 6 by 5. So that will be the way. You will have to examine the right eye separately, left eye separately, and then binocular vision with both eyes. So normal vision for far vision is 6 by 6. And if the far vision is affected, now you can check for the near vision. And you can also check that far vision by hand movements, perception of light, finger counting. That will be the very easy way. And that is done at approximately distance of 1 meter. And you should also examine fundus. So fundoscopy should be done. Near vision is done by Jagger's card. And in a Jagger's card, there are various letters of different sizes. And depending upon what he is able to say, if he is able to read this line, it is called n by 48, 30, 36, 24, 18, 12, 14, etc. So depending upon what line he is able to read, accordingly the number is being put. And that is for near vision. Means he is able to read at the 48, is able to read at 36, 24, 18, etc. So we usually say that near vision is tested when you keep at the distance of 25 centimeter. And if he is able to read all the letters, we say his near vision is good. And this, if near vision is affected, we call that as hypermetropia. And if distant vision is affected, then we call as myopia. So examination for near vision, you have to keep at a fixed distance, approximately 25 centimeter, and then ask the person to read. Person should be able to read very clearly at the distance of almost, we say that 1 to 1.5 feet. So if he can read at 25 centimeter, that is called n by 6. N by 6. So that is considered to be the best. And you will have to examine for right eye, left eye, and then for both eye open together. So instead of this, you can use a confrontation method by finger counting, which will be approximately, you have to hold the card close to 14 inches and ask the person to cover one eye and read the letters. And depending upon which size letter he is able to read, you label that. There are few terminology which are commonly utilized in findings while you do acuity of vision. Myopia is for long sight, hypermetropia is for short sight, or you also call hyperopia or hypermetropia. Presbyopia, very commonly used in an old individual. Amblyopia is a word utilized for defect in acuity of vision, which can be myopia, presbyopia, or hypermetropia. Amaurosis means blindness. Nyctalopia means night blindness. Hemerolopia means day blindness. These are some of the words which can be asked in your oral. Blind spot is the area in which there is no vision, which is corresponding to when the light falls on optic disc. You don't have vision because at the optic disc there are no rods and cones, so you don't have any vision. This area which you can demonstrate in a field of vision, we call that as a blind spot. Other than blind spot, in the area where you don't have a vision, we call that as a scotomas. Astigmatism is cornea. If it is irregular, there will be irregular pattern of vision, that is called astigmatism. And we have already mentioned presbyopia. It is because of the stiffening of the lens. which occurs at the old age person, and it creates difficulty in near vision as well as little difficulty in distant vision also, and that is called presbyopia. There are other terms which are being utilized for short sight: emetropia, E, emetropia; long sight, emetropia; astigmatism, presbyopia. These are the four terms. So instead of myopia, you can call emetropia, AME, and emetropia, that is for short sight, that is instead of hypermetropia. So these are the other terms. You should be aware of it. So emetropia is short sight, EME, and ME, long sight, will be hyperopia, or you can call that as emetropia. So this will be there. And when you have got disturbances of vision, you can correct by glasses. So usually for distant vision, or we call myopia, minus glasses, and for near vision disturbances, or we call as a hypermetropia, you will have a plus glasses. So for hypermetropia, plus glasses; for myopia, minus glasses. So this will be the sum of the things which can be asked. And then visual field can be affected by strokes, glaucoma, diabetic retinopathy, cataract, corneal opacity, etc. And even a damage to optic nerve, optic pathway, as well as damage to occipital cortex. We'll be dealing in detail in the optic nerve pathway and effect of damage to different pathways. So field of vision can be done by confrontation method, perimetry, and computerized. Nowadays, as the computerized is being done, almost it has replaced confrontation method and perimetry. You can do in a vertical field, you can do in a horizontal field. And extraocular muscle movements, you should check simultaneously, because if there is any stigmatism or nystagmus, or if there is any paralysis of extraocular muscle, it will have effect on field of vision, but not on acuity of vision. So extraocular muscle movement should be checked in all the 6 directions. You check for individual eye, you check for both eye together, we call for binocular visions. And this will be dealing in 3rd, 4th and 6th cranial nerve. Then we always look simultaneously for convergence and accommodation response. This is also very important because this will also have effect on field of vision. So this also will be dealing with 3rd, 4th and 6th cranial nerve. So field of vision by confrontation method or by perimetry. So this is a confrontation method. You have to sit away from the patient at the same level, and then you ask the person by doing a confrontation method whether he can identify the moving object. We'll be demonstrating that separately when we have got a lecture presentation. So that will be the way by which you do the confrontation method. At present, it will be difficult to explain you. So when personally I'll be taking a lecture, I'll be explaining that confrontation method. This is the way you do. You have to move your eye in all different direction, all different quadrants, and ask the person when he can identify the moving object, that is moving finger. So these are all the technology which you do for confrontation method. And then you go for the field of vision, and field of vision will be affected, that is in retinal damage, optic nerve pathway, optic radiation, visual cortex, or we call occipital cortex, and also it can be affected by cornea, anterior chamber, posterior chamber, etc. can also have effect on field of vision. So We have to keep this thing in mind. So look for normal field, blindness, homonymous hemianopia, bitemporal, binasal, homonymous hemianopia, scotomas, quadrantic hemianopias, etc. while checking in a field of vision. We'll be dealing in entire detail when we do regarding optic nerve pathway and lesions. You can have also a visual field defect because of a stroke. Because in stroke you can have a damage to the visual pathways. Then this is a perimetry. There are different types of perimeter which are available, but these are all now outdated. It is replaced by computerized. So that can give you an entire idea regarding a field of vision, blind spot, etc. And then we go for color vision. In color vision, you can use color cards, pencil, threads, etc. Or you can use Holmgren's wool, color match, then different lanterns and Ishihara charts. Mainly Ishihara charts is the most common which is being utilized nowadays. This is Holmgren wool which you can utilize and person is supposed to identify the color, but color identification will be based by female rather than male. Some of the male also will be capable of, but this is a rough technology. This is Edrich green lanterns which you can utilize for color vision, and these are called Ishihara charts which are the most common which can be utilized for color vision, and this is mainly utilized by ophthalmologists. So these are Ishihara charts which you can utilize for color vision, and person is supposed to identify what letter is there in these different colors. So you will have to identify those letters, and if you can identify, your color vision is normal. So person is supposed to identify. Say here it is 12, 8, 6, 29, 57, and this is 6. So you will have to identify those different letters what are being written. So here it is 5. So that will give you, or such paintings are given and person is supposed to identify the color. The person who has got a colored vision disturbances, he will be able to see as a black and white instead of color. So try to ask that. You can utilize that. And this can be congenital or can be acquired. Among congenital, person can have a red color blindness or blue color blindness. Red color blindness is very common. And drugs, the most common drugs which we come across in our everyday practice is chloroquine and quinine. They can produce color blindness. So this will be very, very common. And that will produce red color blindness. So this is important, and this is important from ophthalmologist point of view. Do keep it in mind. Then you can go for fundus examination by using fundoscope, and you try to look at the optic disc, the margin of the optic disc, periphery, the arterial tree, arterial branches, venous branches. So retinal arteries, that is artery and vein branches. You look at the fovea. You look at the other retinal field for hemorrhage, exudates, etc. All those you should look for. But before that, you look at the obstacles. If there are any obstacles in the form of lens opacity, corneal opacity, or there is an hyphema, anything in the anterior chamber, posterior chamber, those you should rule out. And then you look for. So you look at the optic disc, then retinal arteries, veins, macula, all those. You examine the entire retinal field. And then you mention regarding, is there any hemorrhage, exudates, maybe cotton wool appearance, neovascularization, then AV nipping, all this that suggests that there is some damage to retinal blood vessels. Copper wire appearance, silver wire appearance, all those are different terms which are being utilized. I am not an expert. And look for if there is any papilledema and which grade it is. Any exudate, any hemorrhage, try to look for retinal detachment. And then another thing what we examine in the eye is the extraocular pressure. One which was used many years back was tonometry. Then finger method is very rough method. Now it is entirely replaced by computerized technology for measurement of intraocular pressure. And that is the most common method which is being utilized. And increased intraocular pressure tells you that there is glaucoma, or we call raised intraocular pressure. And these are those instruments which will be helping you to measure the intraocular pressure. So higher the pressure, we call that as a raised intraocular pressure, or we label that as glaucoma. And then you try to measure the anterior chamber depth also can be measured, and that is also helpful. Then we'll be dealing in the next lecture that is regarding optic nerve pathway and lesions. So I end my lecture here. This was a little introductory part of what is the preliminary part of examination of optic nerve, what you examine in optic nerve, that is first external examination, eyeball movement, position of eyeball, etc., because all this can have effect on acuity of vision as well as field of vision. And then you go for acuity of vision by near vision for distant visions. That is for acuity of vision. You examine color vision. You roughly examine the field of vision by confrontation method, and you can also check by what we call as perimetry or by computerized instruments. Perimetry is almost replaced by computerized instruments. So that is for field of vision. And we'll be talking in the next lecture regarding optic nerve pathway and what are the different field loss, what can take place in lesions at different levels. You also look for intraocular pressure, and you look for color vision by using Ishihara charts or by worm's grain wool. So woolen, different color woolen threads you can utilize. If you like this lecture, please don't forget to press button like, do subscribe, and you can share with your friends. At the end, thank you all for taking out time. I know that your time is valuable, and I appreciate you have spent some of the time with me. So see you in next lecture.